Welcome to The Explainer. Today we're diving into a meticulous, point-by-point clinical breakdown of Dandy-Walker malformation. Seriously, we are covering everything so thoroughly that you won't even need to crack open a textbook after this. We're going to explore the complex structural anomalies of the posterior fossa, and, using these beautiful watercolor-themed diagrams throughout, clear up exactly what you need to look for on a scan. Let's get started.
Here is our roadmap for today. We'll be hitting definition and key concepts, treatments and patient outcomes, CNS and systemic abnormalities, the differential diagnosis, and finally, key differentiating features. Section 1, Definition and Key Concepts. Let's lay down the foundation.
So, the pathology of Dandy-Walker malformation, or DWM, is actually crystal clear once you break it down. It's characterized by the complete agenesis, meaning it just didn't develop, or sometimes hypoplasia of the cerebellar vermis. Alongside that, you'll see a cystic dilatation of the fourth ventricle. This ventricle becomes entirely distorted and encased in a neuroglial vascular membrane. Just picture that fluid, watercolor wash illustrating the posterior fossa, highlighting that missing vermis and the swollen, membrane-encased ventricle.
Historically, it's kind of fascinating. The condition was first described way back in 1914 by Dandy and Blackfan. But get this, it wasn't officially dubbed Dandy-Walker malformation until 40 years later. In 1954, a physician named Benda gave it that name to honor the massive contributions of both Taggart and Walker, who did a lot of the heavy lifting on the pathology in 1942.
To put this into clinical perspective, we're looking at a pretty rare congenital condition. It occurs in approximately 1 per 25,000 to 35,000 live births. So you won't see it every day, but when you do, you need to recognize it instantly.
And how do you recognize it? Well, every time you think of DWM, this classic triad should instantly pop into your head. First, a complete or near-complete absence of the cerebellar vermis. Second, a cystic dilation of the fourth ventricle that projects posteriorly. And third, hydrocephalus. That fluid buildup is incredibly common, showing up in 75 to 95% of these cases. Burn this triad into your memory. Now, biology rarely reads the textbook, right? So DWM doesn't always present perfectly. It actually exists on a developmental continuum. We use terms like Dandy-Walker variant or Dandy-Walker complex when only partial criteria are met. For example, you might see vermian hypoplasia with a fourth ventricle cyst, but no posterior fossa enlargement. I should note, the medical community is currently lacking a standardized nomenclature for this entire continuum, which can make things a bit tricky.
Section 2, Treatments and Patient Outcomes. How do we actually manage this clinically? Treatment for Dandy-Walker is highly targeted to what the patient is actually experiencing. Medically, we manage seizures using anti-epileptic medications. But when we start talking about surgery, the indications are strict. We are looking for symptoms of brainstem compression or hydrocephalus. If surgery is a go, options include shunting, which can target the cyst, the ventricles, or honestly, usually both. Surgeons might also opt for an open or endoscopic cyst fenestration. Occasionally, an endoscopic third ventriculostomy, or ETV, is used, but remember, the aqueduct absolutely must be open for that to work.
When discussing outcomes with patients and their families, clear, honest communication is vital. Roughly 50% of these patients will experience some level of cognitive impairment. Motor issues are also highly prevalent. Think ataxia, spasticity, and poor fine motor control. And as we kind of expected, when discussing the medical treatments, seizures are a reality for about 15% of cases.
Section 3, CNS and systemic abnormalities. Because DWM does not happen in a vacuum. Let's start with the most prominent central nervous system abnormalities. As we mentioned, hydrocephalus occurs in up to 95% of cases, though there's actually some debate on whether it's technically a component by definition or just an associated finding. Next, look at the posterior fossa enlargement. The elevated tentorium produces something called torcula lambdoid inversion. Basically, the tentorium pushes the torcula heraphili abnormally high, right above the lambdoid suture. That is the exact opposite of normal anatomy. Oh, and colossal dysgenesis? You'll find that in 17 to 33% of cases.
We are going point by point here because you need to know this entire list. Occipital encephalocele occur in 7% of patients. You also have to watch for a massive web of associated conditions. We're talking atresia of the foramina of Magendie and Luschka. Other cortical findings include heterotopias, polymicrogyria, ogyria, schizencephaly, and aqueductal stenosis.
You might see microcephaly, lipomas, cephaloceles, lumbosacral meningoceles, or dermoid cysts. Structurally, keep a super close eye on the spine for associated spina bifida, syringeomyelia, or cervical spine fusions known as Klippel-Feil deformity. Like I said, the CNS involvement is extensive.
But wait, it extends well beyond the brain. Systemically, you must look out for facial abnormalities like angiomas, cleft palates, macroglossia, and general facial dysmorphia. Ocular issues can include coloboma, retinal dysgenesis, and microphthalmia. But here is the absolute most critical takeaway from this slide: the cardiovascular system. These patients may present with septal defects, patent ductus arteriosus, aortic coarctation, or dextrocardia. Why does this matter so much? Because you must always screen for and be completely aware of cardiovascular abnormalities before you ever bring these patients into the operating room.
Section 4, the differential diagnosis. How do we distinguish DWM from lookalikes? Let's start grouping our differentials. We already know numbers 1 and 2, DWM and its variant, DWV. The third key differential you need to know is a persistent Blake's pouch cyst, or BPC. This features tetraventricular hydrocephalus, along with a communicating fourth ventricle and posterior fossa cyst. Now here is a vital clinical pearl for differentiating. In a Blake's pouch cyst, the vermis and medial aspects of the cerebellar hemispheres might actually look hypoplastic on your initial imaging, but don't be fooled. They usually re-expand after shunting, even if a little pressure atrophy has occurred. True DWM agenesis obviously won't ever re-expand.
Let's keep building our list with other cystic structures. Number 4 is a retrocerebellar arachnoid cyst. This can produce significant mass effect, essentially pushing the fourth ventricle and the cerebellum forward. But crucially, the vermis remains perfectly intact here. Number 5, if you suspect an epigamoid cyst of the posterior fossa, check your DWI imaging. It's going to show restriction. And number 6, simple cerebellar atrophy will present as a generalized volume loss all over, rather than the targeted agenesis we see in Dandy Walker.
Rounding out our differential, number 7 is Joubert syndrome. You have to rule this out because it also features an absence or underdevelopment of the cerebellar vermis. Number 8, you have normal variants, like an enlarged or mega cisterna magna. This is actually found in about 1% of all imaged brains. While it gives you a secondarily enlarged posterior fossa, the vermis and fourth ventricle are totally normal, and importantly, there is absolutely zero mass effect on the cerebellum. Lastly, number 9, always keep cystic posterior fossa tumors in the back of your mind. Things like a pilocytic astrocytoma. These will typically feature an enhancing mural nodule on your imaging, which is a dead giveaway.
Section 5, key differentiating features. Let's synthesize this into radiologic absolutes. If you take a look at this comparative table, it brilliantly lays out the absolute differentiators. When comparing against lookalikes, focus strictly on 2 things: the vermis and the choroid plexus. Retrocerebellar arachnoid cysts and BPCs lack true vermian agenesis. Next, track the choroid plexus of the fourth ventricle. In DWM, it's completely absent. In arachnoid cysts, it's normal. And in a Blake's pouch cyst, it is distinctively displaced into the superior cyst wall. Finding that choroid plexus is literally your definitive roadmap.
Another great tool is an intrathecal enhanced CT scan because it dynamically shows us fluid flow. If you instill ionated contrast, an enlarged megacisterna magna will actively communicate with the ventricles. Conversely, a Dandy Walker malformation will not communicate at all. And, as a quick side note, most, but not all arachnoid cysts also fail to communicate.
As we wrap up this comprehensive explainer, I want to leave you with a provocative thought. We've seen today how Dandy Walker really exists on a complex developmental continuum. Given this fluidity and our current lack of a universal naming standard, how will strictly defining the boundaries of the Dandy Walker complex eventually reshape how we surgically approach these anomalies? Will standardizing the nomenclature literally change who goes to the OR and who doesn't? It is a fascinating area of ongoing neurological study. Thank you so much for joining me, and keep questioning what you see on those scans.